Well, thank you. So happy to be here and share kind of what we've been doing in Georgia because, I mean, we're really, I guess if I had to say in a nutshell, we're essentially on a massive scale building out new teaching hospitals. As Atul was saying, we have lots of hospitals that don't teach residents in Georgia that can do an excellent job. And so that's basically the journey we're going to be talking about. So some objectives here, kind of just talk about the approach that we've used, and we've had great support from our Board of Regents and the state taxpayers really in Georgia to do what we're going to talk about. What are the challenges for bringing up a new teaching hospital? Because they are many, many, many. We don't have time to go through all of that, but what are the funding issues? That's a big issue, and we'll talk about how Medicare addresses that or does not address it, in fact, and then what has been our success to date. So a little bit about me. It is a mouthful, the GRU-UGA Medical Partnership. We are a 4-year medical school campus of the Medical College of Georgia, but for the purposes of GME, we're accredited separate to sponsor residency programs out of Athens, and my main job in coming to Athens was to build out new teaching hospitals to partner with the new medical students that were going to be in Athens, Georgia. And so that was my journey from West Virginia to Georgia. So a little stats, as Atul said, Georgia ranks very, very poorly, as you can see here from stats the AAMC's put together, which is very, very low for primary care docs per capita. We have about 10 million people that live in Georgia, and it's rising rapidly with the good weather. And then, of course, our resident to population ratio is very, very low, you can see there. The bulk of our residents sit in the two main medical schools, which is Emory and Atlanta, which has about 2,000 residents, and then you've got Augusta, which has about 400 or 500 residents. The rest of the state, for the most part, has a few trickled out sparse areas of training, and Georgia's a very large state, not as big as Texas, however. Rural hospitals, though, are eligible to get new Medicare dollars, so that needs to be a target. Atul talked about this nicely. Georgia is a very good state in retention. And so if you look at how we rank, we're 11th in the nation if you complete medical school there. As he said, you add GME, and we still do very well at retaining our residents. So one of the angles and one of the points with the legislature, the governor, and the regents was we do really well at keeping our students and residents here. Let's do a build out of new teaching hospitals and get the more rural areas targeted in hopes that then they stay there and practice. And that was our main philosophy going forward. So what do you need to think about? Sustainable funding is expensive to train a resident. Most data tells us at least $160,000, $180,000 a year to train a resident. That's for all overhead and such, so you've got to have a way to generate those dollars. We want to distribute these programs. As I said, we know residents will stay where they're likely to train. We've got to focus in Georgia where we are in dire straits. That is absolutely primary care, but it's surgery. It's also psychiatry as well. We just don't have enough of that. And then I think you need to build strong partnerships with the community, the federally qualified health centers. Again, a big angle that we're looking at. How do you build out a resident clinic and partner with a federally funded entity and serve as their training zone? So why would a new teaching hospital want to do this? I've sat in C-suites and CEOs and vice presidents of every part of the hospital trying to understand this. Well, why would we want to do this, Dr. Nuss? Well, I'm not going to read these off, but recruitment is a huge cost for hospitals. We're talking $75,000, $100,000 for recruitment costs for one doc. If we can grow our own, right, more likely to stay there, we cut those costs. Most data shows there's a higher quality of care that's delivered, clearly enhances the teaching doctors because they've got to be on their A game now because those residents ask the really tough questions, so do the students. And I think it just increased public market prestige for that hospital to become a teaching hospital. So you can see through the rest of those. So as we know, the current hospitals in the United States were capped in 96, end of 96 into 97. Medicare is the largest public source of funding, as we know. Georgia is a state that still uses Medicaid dollars to fund teaching hospitals to the tune of about $90 million. As you know, most states and many are not supporting anymore the teaching hospitals. Georgia we have, and there is no threat to that I'm aware of. The very good thing that CMS allows now is for new teaching hospitals to come on board and actually get a new cap established. And the cap window is now a 5-year period. Thanks to advocates like the AAMC and your support, we've been able to extend that out. I think the one hitch here, though, and where I got the cold feet from the hospitals was Well, Dr. Nuss, where are we going to get those startup costs? Who's going to pay the directors, the accreditation fees, all the necessary infrastructure to do this, and what are those costs going to cost, going to cost the hospital? And so that was where we started the dialogue with the Board of Regents. It takes a minimum of 2 to 3 years. The Regents didn't get this at first in Georgia, and the governor, they thought, well, why can't you just start a resident in a hospital? It doesn't go like that. There's a lot of steps, a lot of recruitment, a lot of other things that have to happen to get that on board. So estimates and what we're finding in Georgia is that startup costs are anywhere from $2 to $8 million, depending on the volume of the programs that you want to put up. Surgeons cost more than internists like me, so do obstetrics and gynecology. And I'll show you that data in a minute on what our budgets have been. And so no Medicare dollars start to flow to those hospitals till the residents actually are on foot in the building. So that 2 or 3 ramp-up period, there's no dollars coming in for the hospital. And that's where we really targeted the state of Georgia. This is a busy slide, but this is the cost for just one program, an internal medicine program going up. There's personnel, which is a good chunk of it, and non-personnel costs. And of course, the personnel will repeat itself in year 2 and 3, because you've got to hire the docs to do it. Overhead for the non-personnel stays the same. So you can see in this example, it's about $2.2 million, plus again, you'd repeat the $838,000 again. For 5 programs coming up, again, the directors cost more, it's more complex, and your personnel costs go up. So you've got $3.7 million for 1 year, and then you've got to repeat the personnel costs again. So again, anywhere from $2 to $8 million. So what we did in Georgia is that we pulled GME experts from the whole state, from Emory and Morehouse and Mercer, PCOM and MCG, and I was part of that crew, and we proposed to the state legislature an expansion of 400 residents across the state. That would barely bring us, folks, to the southeast average of resident physicians per capita. To get to the full national average of bigger states like Ohio and others, we'd have to add 1,600 residents. We thought that was too much to bite off with the hospitals we've had. So we proposed a funding model for those startup costs, because that's where the C-suite got the cold feet. Well, who's going to pay for that $8 million, Dr. Nuss? We knew new teaching hospitals could participate. We had to focus on primary care and general surgery. Hospitals had to have some skin in the game. So we proposed a funding model where hospitals would put in half the dollars for startup. So it wasn't just a free handout to the hospital. The governor and legislature, with a lot of work, bought into this and were very supportive as they saw the physician crisis looming. It takes many, many years to train a doctor, 4 years of a bachelor, 4 year of med school, minimum of 3 year residency. You've got to start now. You can't wait 5 and 10 years later. So we actually got them to support this in fiscal year 13. These are the dollars so far that Georgia state taxpayer dollars have put forth in this GME expansion model. So over the past 4 years, $14 million. The original plan was for $22 million, and I think this program is going to continue as long as we have support and build out of the hospitals. This is the progress we've made, and so at this point, this is what we're on track to build out, is 20 new programs across the state of Georgia, located in more rural, underserved areas. Again, that drives where we get residents and then more likely to access care for the Georgians. And so we're on target right now, probably by fiscal year 17-18, because it takes a while to get all the residents ramped up, that we will have a success. If we can get Gainesville, Georgia to come on board, they're going to put another 150 residents out on top of this, actually, if we can do that. So, and that's up in northeast Georgia. This has not been an easy journey. As I said, my work started in August of 10, and we are just now landing the first residents in Athens. So we have an internal medicine program starting in July. We matched 10 right out of the gate, which I think is a success. Difficult for a fourth-year student to put down on their match list going to a new residency program. So we have a lot to offer in Athens and what we had going on. So lots of challenges. The medical staff, I talk about this as kind of the ground-up approach. This cannot be a top-down C-suite telling the medical staff they're going to be a new teaching hospital. You've got to build the support from the medical staff. They're the ones teaching the residents, and that's where their program's built on high quality and excellence. So you've got to get them willing to participate. You need champions on the ground in that community and understanding the local politics. And it's just a mission change for the hospital. The hospital we're working with has changed their mission statement. They're now in the education business of students and residents. That's a culture change for the hospital, for the community, for really everybody in Athens, and it's been very exciting to watch. And so lots of issues and more challenges for more complex things like neurosurgery and orthopedics. That would be even more complicated. And again, the financial constraints. So in summary, again, we know there are national and state physician shortages. Georgia struggling more than most states in terms of primary care and the surgical subspecialties. It is very complex. It takes a lot of support from the key stakeholders to get this to move forward. The GME startup costs are significant, and that's where Georgia has really been a huge support for that. And so on track for 400, again, and strong partnerships with FQHC and such is very, very helpful. And the Teaching Health Center grants, thank you, that did go through under the SGR package. And so that will support those funds so that those residents can continue to have support. So I think the other thing, too, is that there's 170 hospitals in Georgia. Only 16 were teaching hospitals when I arrived there. And so we're on track to probably bring up, we have 7 right now bringing up new residents, but we hope to expand that to about 11 to 14 new teaching hospitals in the state of Georgia. So thank you for your time. I'll be happy to answer any questions.